When a patient switches in a session, many therapists feel a jolt of tension, especially when that part seems to be controlling or dominant or seems to be wanting to show off his or her power. But should we be afraid of it? Should we try to prevent it? Even if it's for the sake of making progress with one dissociative part. In this video, Ellert Nijenhuis will answer these questions. Chronically traumatized patients may have dozens of dissociative parts. It's not unheard of that there are up to 90 different parts or agents who actually can act in the world. So for the sake of maintaining some kind of overview or believing that you are making progress with one or two dissociative parts, it may be worthwhile to maintain some kind of door policy in the therapy room. But is this really the therapist's responsibility? This is what Ellert has got to say about it.
I'm very open to allowing it in as much as I can appreciate, understand, grasp that it's useful, that there's a point, that it leads us somewhere. If you want to lay a puzzle with 20 pieces, you need the pieces.
As discussed in previous videos, Ellert talks about 3 prototypical dissociative parts, or as he prefers to call them, agents, as these parts have the ability to act. These agents are the ANP, the apparently normal part, that tries to live daily life and is a master of ignorance, the fragile EP, that's the fragile emotional part, and the controlling EP, controlling emotional part. Especially meeting these controlling EPs can be an intense experience for therapists. What advice does Ellert have for therapists on this topic?
If it's the patient way to show it in that way, that it doesn't go through the adult one indirectly, but when other parts, the emotional parts, show themselves directly with a lot of aggression, my basic attitude is, hello, you come by today. What's your point? Why is that important? And that approach basically has always helped me. They do have a point, and every part wants to be seen, heard, felt, and respected, even if they initially can sometimes show a rather aggressive part, at least apparently aggressive. And I take that to be an indication where the patient as a whole is saying, Ellert, this is also me. And I can't relate to it as the adult one. I need to find a way. Can you help me deal with that? And in that sense, we are kind of bridge.
So should therapists be afraid of dissociation?
I do notice my intuitions also. If it feels uncanny and not right, take care. I once was invited to do treatment with a lady, and as she switched in front of me from one part to the other, they were all antisocial. Absolutely antisocial. A very complex case where we had DID and most of the parts being antisocial. And I felt I cannot handle this on an outpatient basis. Thus, in that case, I entered discussions with a psychologist in prison, and we admitted her to prison, to forensic psychiatry. And there, the lady made serious advancements, but in this frame, that was unthinkable as far as I'm concerned on the outpatient basis. But I've also treated a man who was in prison, and he was allowed to go out of prison, but he didn't dare to. And they thought he had become hospitalized. That was not the case. A colleague of mine who knew a little bit about dissociation said, I guess this guy is dissociative. We have not seen that for 12 years. He had been in prison for 12 years for murdering a person. And I met him. I liked him. We had guards sitting in my private practice. It was a kind of peculiar situation. We had 2 guards sitting in, to the left and to the right of them. I treated him with the guards present for his DID. It worked very well and quickly, actually. And at some point he said, Ellert, I need to discuss some things with you, and it's too difficult, too hard. They were of a sexual nature to have the guards sitting in. Would it be okay? By that time, I trusted him, and we had the guards sitting on the other side of the door, and I was sitting at a distance of 4 meters from him, so that in case of trouble, I would be saved. We searched him for weapons as he entered therapy room. He totally accepted that. There was no resistance whatsoever. We had a good collaboration. And then at some point, we had to work with a very, very aggressive part in him, the one who actually had committed the murder, so to speak. And I thought, oh, that was heavy, but I knew hypnosis, and I thought, for what it's worth, I'm going to lame his body. We're going to do body paralysis. I never tested if it was real or not, but he was sitting there, and the stuff that came out was absolutely aggressive. But I could keep up with him, and we dealt with the matters at hand, and he calmed down and was integrated in a few sessions, and that was the end of it. This man cured his DID in collaboration with me in 70 sessions in total. That was all. Sometimes I like these experiments, but I was not a fool. I've never been threatened by patients in any serious manner. Thus, intuition, I'd like to communicate, is important too.
If you are a therapist and have a question about dissociative disorders, then please leave a comment. We're curious to learn what you are struggling with. For in-depth training, we have an online basic course that will help you treat severely traumatized patients.